program, Professor Ashish Sharma from PG Chandigarh, and esteemed colleagues in MMC, the Director Urology, Professor of Urology, Director Neurosurgery, Professor Anesthesia, HOD Emergency Medicine, other faculty of Nephrology and Urology, respected HOD Surgical Gastroenterology. Ladies and gentlemen, a warm welcome to you all. This is a new initiative of, a joint initiative of Transplant, that is Transplant Authority Tamil Nadu and Madras Medical College. Wherever science enters, the program prospers. I have a very strong belief in that. We have to infuse the scientific input to any program and any work which we do. I'm a strong believer in this, and all the more so in diseased organ donor transplant program. The science is evolving. Still there are a lot of gray areas, a lot of challenges and so on. So the Transplant MMC decided to initiate a lecture series. I'm optimistic that we'll be able to do at least one session every month, if not one session every month, at least once in 2 months. That's what is I'm envisioning. To start with, we have an esteemed personality in the arena of organ donation and kidney transplantation program, none other than the HOD Department of Transplant Surgery, PG Chandigarh, Professor Ashish Sharma. First of all, this year has been a kind of a very vibrant, the year that passed by, 2023 had been a very vibrant and fruitful year as far as diseased organ donation is concerned. In Tamil Nadu as a whole, we were able to identify and achieve 178 deceased donations, the highest number after 2016. That's been covered in some media as well. And with the total utilization of major and minor organs put together, 1,000 organs were used. Having said that, even though we feel little elated about it and we can't remain complacent, and there's nothing to be buoyant about it, because the potential for Tamil Nadu is much, much, much more than what we have achieved. And I'm very optimistic, and in the years to come, the Transplant and all other institutions of Tamil Nadu will do much better. Coming to MMC, Madras Medical College, with the able guidance and leadership of our beloved Dean, certain new initiatives were introduced. To name a few, Sir actually constituted a core committee comprising of HOD Neurosurgery and Emergency Medicine, Dr. Bhamati, and 2 young colleagues in Nephrology and Anesthesia. The core team, then this team used to get input from other specialists as and when required. The entire process of brain death, identification, certification, maintenance of deceased donor, and everything was kind of protocolized. We all sat together, and the institution's protocol has been finalized, and of course the protocol is not the final draft, and it needs and requires amendments as and when things evolve. But this development of a protocol and kind of streamlining the whole lot of it has been a major step in the success, major reason for the success in the program. In a single calendar year, 26 brain death certifications took place in this institution. This is the highest number from a single center across the state of Tamil Nadu. And again, our beloved Dean Sir introduced another important initiative, in the sense that offering honor walk for the deceased donor after retrieval of all the organs. A big gathering. In fact, the first honor walk, still I remember, it was odd hours, around 11 p.m. From 300 to 350 people, students and staff and faculty, everybody gathered, and we paid tributes and homage to the deceased donor, standing in 2 queues, and when the mortal remains of the deceased donor was taken out in a procession. We just wanted to kind of show this gesture, good gesture towards that supreme sacrifice. We didn't realize that this single step will lead on to a cascade of so many positive developments. And that is the beauty of our dean, whatever he says. I was just describing about our dean to the distinguished guest of honor in just one word. He's an alchemist. That's what I said, capable of transforming anything into anything. So what happened is that now that attracted the wider attention of the public, and the media, and the political dispensation, and the bureaucracy, and so on. And subsequently, thanks to our Honorable Chief Minister and the respected Honorable Health Minister, he is very, very particular about the program. The government of Tamil Nadu, the current dispensation, is very keen to promote the disease organ donation because they know the pain of the suffering of the people with organ failure. First of its kind in the entire country, the Honorable Chief Minister made an announcement saying that we should not stop short with honor walk, and actually the tributes have to be paid to the deceased donor in their respective places. Even in a remote village, maybe in a remote village or a town or panchayat or wherever, on behalf of the state of Tamil Nadu government, an official of the rank of a district collector or an equivalent cadre has to pay respects the residents of the deceased donor. That was the announcement, and subsequently it was formalized into an official government order, the first of kind it's in the entire country. And that has created a big spark in the program. After that, after the announcement of that, on September 23rd, one diseased organ donation, one diseased donation is happening once in 48 hours. Once in 48 hours. Such a big leap. Such a big leap. If you see, in the month of December, entire Tamil Nadu, 25 centers, 25 donations happened in one single month. If that trend continues, this year we will see more than 250. In fact, you will not have time to take care of so many organs. So there is a resurgence in the entire program. There is a big moment, there is a momentous period we all are passing through. And we all, being a technocrats involved in utilization of these precious organs, I think we have to get more and more sensitized, and we have to take a resolve to kind of contribute to the maximum extent into this program. And another important step is that I told about the core team, Professor Raghavendra, Professor Gomati, Dr. Tanu just left MMC, my colleague, my junior colleague, and Dr. Jayanti and all. They played a very, very, very vital role, because you know, maintenance of the deceased donor is not an easy job. And even certifying brain death, there are so many gray areas, a lot of challenges and so on. It requires the continuous monitoring and continuous flow of information has to take place among the different stakeholders and the people involved in the program and so on. They all gave their extra time and focus and energy into the process of this. Special thanks to them. And I hope and wish, and my special thanks to my urology colleagues and my own colleagues in nephrology, and the great help from anesthesia department. You know, the surgery in the odd hours of the day it takes place, and it is not easy. In addition to looking after the regular anesthetic emergencies, regular surgeries and so on, they have played a very crucial role in immunology. The cross-match test is being done any time of the day, and in-house availability of the immunology lab, that is a pivotal help for us and all other support departments, nursing staff and paramedicals and microbiology and transfusion medicine. I mean, it is the collective work of so many departments under the guidance of our dean. So I'll briefly introduce the speaker as well. I welcome our vice principal as well, Professor Ashish Sharma. He is the head and department of renal transplant surgery at PG Chandigarh. He was ex-vice president of Indian Society of Organ Transplant. He is the founder secretary of Pancreas Transplant Society of India, and is the managing trustee of Organ Transplant Trust, PGH Chandigarh. He has shown actively involved in promoting diseased organ donation at PGH Chandigarh, leading to more than 550 deceased donor kidney transplants he has performed, and initiated simultaneous kidney pancreas transplant at PGH Chandigarh in 2014, and he has performed 43 such combined kidney pancreas transplants so far. And he has formed a protocol to successfully perform donation after cardiac death, which is not there in Tamil Nadu so far, which has led to 28 kidney transplants from such donors. And the most important development is that he has been instrumental in starting MCH course in transplantation, a 3-year course after MS, general surgery, and a fellowship in pancreas transplantation, PG Chandigarh. And he has developed vascular access program including ultrasound guided angioplasty with more than 1,600 access procedures per year. And his center is the first center in entire Asia and 5th across the world to start normothermic perfusion of kidneys. And he is a member of National Advisory Committee for formulating guidelines on deceased donor transplantation, and he is also a member of National Health Authority. To his credit, he has more than 200 publications in reputed national and international journals. Welcome, Professor Rajesh Sharma, to the historic MNC. I would like to offer our honors and felicitation to the respective team. MS Madam, please be on this. Please come on.
Member Secretary Professor NGK Sir, Vice Principal Dr. Kavita, the Directors, Professors, Associate Professors, and my dear postgraduate students. Very good afternoon to all of you. At the outset, I would like to thank Professor NGK Sir for having this CME, arranging and inviting Professor Ashish Sharma to talk about organ transplant update series number 1 CME. You all know, after Professor NGK took over as the member secretary in transplant, there is a positive wave across the state. Starting from Madras Medical College to Kanyakumari, almost all the new colleges also started doing the organ retrieval. Recently, Namakkal Medical College also done an organ retrieval because one of our PG been posted for DRP posting in Namakkal. He only identified the emergency medicine postgraduate of MMC, identified organ brain stem dysfunction. Finally, it was converted into organ donation. Same way, even in Krishnagiri Medical College, they have done an organ retrieval. And Dharmaburi, almost 10 organ retrieval has been done in the year of 2023. So, not only in Dharmaburi, all the new medical colleges started doing this. So this type of awareness and sensitization has been established across the state. And after Professor NGK took over, lot of changes, lot of reforms he brought in Transplant. He was the person behind this honor work. He has been telling that honor work has to be done for this organ retrieval patient. And one fine day, we decided to conduct honor work. That was actually came in all the medias. Then it attracted our bureaucrats as well as our political leaders. And then finally what happened, the government has come out with the GO. Now almost each and every district, even the remote areas also, either the public officials or the political leaders are paying the tributes to the departed souls. So that much of awareness sensitization has been done in our state, and as you all know, the Spain is leading with the 47. They converted organ ritual out of 1,000, whereas in India is the very lowest country converting the organ ritual. But in India, Tamil Nadu is leading the country. So because of that, many lives, quality of life has improved, and the survival is improved, and also the patients are now almost in the verge of death. They go for the final treatment of organ transplant. The organ transplant is happening in almost, they do renal transplant, liver transplant, kidney transplant, pancreas, intestine, skin, testes, penis, almost all the organs they are doing the transplantation. In our hospital, still I remember a 27-year-old man donated his organ after the brainstem dysfunction. And the same day, liver transplant took place in our institute, heart transplant took place in our hospital, renal transplant took place, then cornea also took place. That is possible because of this organ donation. I think this is very, very important program. I think SAR is leading the state very well. Sure that SAR will lead the entire country. That is not far away. So with this, I conclude my speech, and also I wanted to thank the speaker having accepted our invitation, and in his busy schedule he has come all the way to Tamil Nadu, and I am very, very eager to listen to his speech. At the same time, and I request the postgraduate, or not postgraduate or assistant professor in the general side, if whoever is willing to take up some training in transplant study in PGH Chandigarh, I am ready to forward it, and I am ready to discuss with this DME and the health secretary. We will send them for a training, and once you come back, I think definitely the organ ritual program will be a good lead. Thank you for the opportunity. Thank you.
Dr. Tina Rajan, worthy Dean of MMC, Dr. Kavita, Vice Principal, Dr. Gopal Krishnan, Head of Nephrology, Dr. Gomti, Head of Nephrology, Neurosurgery, and various faculty colleagues, residents. It's a kind privilege to be here talking regarding the first lecture of this series. So, when I was invited for this talk, I had my own apprehensions. I mean, Tamil Nadu is a leader. I come from a region where there is hardly any donation, so me talking about organ donation to faculty of MMC would be like showing light to the sun. So, is it all worth the effort? But then I realized that it may be a two-way affair, that I possibly will need learn something from here, and we as a center, not as a region but as a center, has done a lot of work in this area, and maybe we can have a collaboration, and we can invite, or maybe we can impart some areas of training or research which can help the programs go further from where it is already there. So with that, I think this is not going to be a one-way lecture. I want it to be a two-way interaction, so I want some feedback from the audience. We had some very good discussion with the Transplant team who's here today also, and Dr. Gopal regarding what is happening here and how we can work further. So with that, I'll start my talk. So we've got no conflict of interest, and whatever pictures and data we see today, all consents have been obtained from the patients. So when I took up this topic, so I restricted myself to the next decade, and the reason for that is not difficult to believe. I mean, it's a technology, it's a digital age which we are passing through. The technology has become so disruptive. Typewriters, we've seen the demise of typewriters, the cameras, right? And typewriters probably took about 10-15 years to go, the camera took about 5-6 years. But now the technology is so disruptive. One tweet from the Prime Minister regarding Lakshadweep and the entire Maldives is shaken, right? So it has become so disruptive. So we actually cannot focus too much on the long term. So here's a picture. So Can anyone tell me what is this picture about? It was all over the Twitter over the last couple of years. Any residents? I think residents are they're too active on social media, so they would be probably knowing what this picture is all about. Anyone? Do we have residents here? Can I have a show of hands? Who? Oh, so we've got a lot of them here. Okay, I'll add another picture to this. I hope you can see the kidney and the heart. So can we put one and one together? Okay, so that's a clue. Xenotransplant, right? So that's the power of technology, right? We could actually transplant a pig heart into a human and into a pig kidney into a human, and they could work for some at least a couple of months, and with no evidence of rejection. With the immune suppression is as similar as to what we give in normal transplant. So that's the power. That's a technological disruption. And if this technology comes today, I mean, there's already a startup company in the US, and if it happens today, all our talk becomes fruitless, right? All about organ donation and everything comes to a no. So that's the power, right? So with that in background, I thought I'll just divide my talk into a few topics. So each of them actually can be talked at length into a full lecture, but I'll try to be short and crisp. And I recognize that it's a mixed audience, and I apologize that if some part of my talks are too technical, which may be only understood by the nephrology and urology colleagues, right? So before we start, we always compare, and what do we have to compare? We compare with the world, right? We say that Indian economy is growing at a rapid pace. So can anyone tell me what is the position of India in terms of economy? Anyone from the residents or faculty? Are we number one? Yes or no? No. Okay, so we know that we're not number one. We're at number 5, so which is not a bad place. I mean, you still are in the top 5. So is it? So are we happy with our economy that we are at number 5? Please, can we have some? Yeah, we may be at number 5, but if we talk in terms of per capita, right? We are at number 140 amongst, I think, maybe less than 200 countries. We are at 140. So it's not a very happy situation, of course, but it gives you some strength being at number 5 in the world, right? So what is happening with organ donation? I hope my slides are visible. So India is at number 3 in terms of total number of organ transplants being performed, which is a remarkable feat, right? But at the same time, same as with the economy, we have like a billion plus population, and if you see where are we in terms of donation per million population, that is how we calculate. If you have a million people, how many donations does India do? Spain and US are at the highest. They do about close to 50 donations per million population. And where is India? India is at the bottom rung, right? So this is 2021 data. So we may have moved a little bit more because that was post-COVID, but we're still amongst the lowest 10% of the countries, right? Less than 1 million population. So there's the second part of my title, challenges as well as opportunities, right? So it is a challenge, but at the same time, it gives you an opportunity to break this and create it to an opportunity, right? And that's what we are here today, what we can do. So these are some historical data from the United Kingdom. So almost all populations across the world go through a similar phase. They are backward to begin with, then they start to grow, they become economically better. From a developing, they go into a developed stage. So we are at the moment into a developing stage. So if you see that there are 3 lines in this. The top one is the green line, this one. So that's the number of living donor kidney transplants being performed in the United Kingdom. The second one is the blue one is the donation after brain death, and the third one is donation after the cardiac death. And this chart shows from the last 15 years how things are moving. So if you see that the living donation was increasing at a rapid pace, it doubled and probably plateaued somewhere between 2011 and 2014 in the UK, and after that it's showing a steady decline, right? Why is it happened? We'll come to it later on. And if you see the donation after brain death, it has increased, but possibly is again plateaued now, right? And what is increasing now at a rapid pace is the donation after cardiac death. So, is it related to only one center in the world? So I saw the data from the US, and again we saw a similar pattern there, right? So from 2005 till 23, there's a subtle decline happening in the number of living donations, whereas your donation after brain death were increasing till last year. But what is happening now is an exponential increase in the number of donations after cardiac death. Where are we in India, right? So in India, we are still in growing phase of living donation, right? So we possibly are in an area. So this is a chart where I have overlapped the US and the Indian data. So although we are increasing, so we possibly are in this region. So we have to increase further before we enter the plateau phase as far as the living donation is concerned. But where are we as far as the donation after brain death is concerned? Way behind, right? In the living donor, we almost are like matching, or rather we are now ahead. India does the maximum number of living transplants in the world. And donation after cardiac death, we are down to bottom zero, right? So nothing is happening in the country except for center at PJ and occasional donation happening elsewhere in the country. So the same figures, if you compare with other countries across the world, we're not very bad in terms of living donations. So we are somewhere in the middle of the list, right? But if you see the highest country, Israel and Turkey does about 6 times more living donations than us. If you look at the developed countries, the UK and US, they're about 2 to 3 times the number of living donations what we do. When we come to the disease donor transplant donations, India is down there, right? And if we compare in terms of the time, so the leaders are doing close to 100 times the donation what we do. So that is the kind of gap we are looking at as we go into a developed economy. That is what we have to bridge. It's not going to be easy. We don't have manpower, but there again, there's an opportunity here to lead this and show the light to the world. And have we done it? We've done it in some ways. We've created a very new initiative from the worthy Prime Minister, Ayushman Bharat. Nobody could imagine 10 years down the line, we always used to hear there are so many kidney failure patients. 1.5 lakh is the figure which is quoted. So many people require kidney failure in our country. But we never used to have list. I don't know how much is the waiting list in Tamil Nadu. Any idea? So only 6,000. The figures quoted for the country is 1.5. So where are those patients going? So all of them were actually dying because of lack of affordable therapy, right? Patients with kidney failure, the nephrologists never used to tell that, okay, they will say, okay, at least in my part of country, okay, we'll start dialysis. They never tell that the dialysis is going to be there for the rest of the life. The moment the patient realized that dialysis is going to be required for the rest of the life and it's going to cost at least 30,000-40,000 a month, they will just stop getting dialysis done. But now that has changed. Ayushman Bharat has led to 50 crore people getting the benefit. Can we sustain it? I don't know, but here the number of beneficiaries, as they keep on increasing, the demand for the transplant surgery is growing at an exponential pace, even in our country. So same is true for dialysis. With the support of dialysis, these patients are now able to live till they get a transplant. So all that means that we need to grow in numbers of our donations, right? And how can we do it? So this is some data coming from Apex Institute, All India Institute of Medical Sciences, Delhi. So this is the data from the trauma center with a bed capacity of 254. So they mentioned that year-wise, how much deaths are happening there. Around 440 deaths in 2023. 230 of them were actually because of irreversible brain injury. they would identify 139 brain deaths, declare 38 of them, of which 14 families decided to donate the organs of their near and dear ones. So I want some feedback from the audience. So how can we improve? I'm sure this is the picture elsewhere with some tweaks and all. So what are we looking at here? So anyone can anyone give an input? What is the striking thing here? Anyone? So what we have the data now and how to improve it? So what is the big problem here and what needs to be addressed? Yes, so who are the residents, the nephrology or anesthesia residents? Let's talk with the anesthesia residents. Please. I mean, you can be wrong. I mean, there's nothing wrong or right here actually, right? So it's all an opinion. So collective opinion is always better than a single person's opinion. Yeah, please. Yeah. So I think that's the most striking thing here, that you could identify 139, but you could declare only 38, right? The biggest positive from what I see from here is that actually you got data. This is the first time I'm seeing actually data coming from a reputed institute where they've actually acknowledged that we are actually having so many deaths, right? Till this data, we were only thinking and focusing on the public awareness campaigns. We thought that okay, public is not aware, brain death is possibly not happening, but now we know that okay, you've got so many people coming with injury, and we are only able to declare less than 1/4 of patients who are brain dead. But if we talk of total deaths because of cerebral injury, that figure is even higher, 230, right? So potentially all these 230 are donors whose organs can be utilized in some way or other. And the last part is the consent rate, which we are trying to address with public awareness campaigns. This data coming from the state of Tamil Nadu, where we have much higher conversion rates, right? And I was told by Dr. Gopala Krishnan that consent rate, possibly consent rate in our institute is close to 80%, which is very good. Yeah. Yeah. So well, these are there, but where do we stand in terms of number of ICU deaths? We need to know that. And where are we in terms of patients dying because of devastating it? 100% these patients with cerebral injury, all of them, or nearly 90% of them can be utilized as, or their organs can be utilized. So I'll give you some case scenarios. It very commonly happens, I don't know what the situation here. So patient with devastating brain injury, but he was there in moving around in different hospitals. By the time he landed up with us, his potassium is 2.3 and sodium is 180. So would this patient be declared brain dead right away? Can we do a brain death certification committee? Dr. Gomti, please. Yeah, so I know. I mean, so people like we have a dedicated. Please sit down, please. So we have dedicated. We are lucky that you have people like Dr. Gomti who are dedicated to this cause, but it's not frequent happening across elsewhere. And the time is the crux here. So, and many times this is actually beyond the correctable stage, and this patient has a cardiac arrest, right? So second patient again. 51 years old female. This is about 10 years back. Lung donation wasn't a possibility in our country. It still is like done in a very few proportion of patients. Family was aware of end-stage organ failure. They are suffering day in and day out from end-stage lung failure, and they said, okay, if other organs are okay, why don't we go ahead and donate? She's definitely going to go ahead with the cardiac arrest. So what do we do here? So fortunately, we have a protocol. So both these patients had a cardiac arrest. and we could utilize these organs. And the patient on the left side is now 9 years post-transplant, enjoying a normal life, EP creatinine of 1.03. The second patient was our first index patient where we attempted donation after cardiac death. Unfortunately, one of the kidneys never functioned, other had a suboptimal function, but worked for about 5 years, and he underwent a second transplant afterwards. But the heartening message is that we could actually utilize these donors, and these are not uncommon, these are very common, but you can use these, right? So for those of you who are not aware of what is brain death and what is circulatory death, so these are the different differences. So brain death is you've got irreversible injury to the brain, where the patient can be managed on a ventilator, and you have all the time to ask for consent from the relatives, and you've got time to organize organ donation. Whereas once the heart stops, you've got very limited time to get the organs out. So if you do it within 30 minutes, you can use most of the organs, but that is very impractical to talk about. Even at our center, where all the teams are always geared up and having 10 years of experience now, we are never able to achieve a time less than 60 minutes, right? With that, we still can go ahead with donation, the kidney donations. Other organs are not utilized. But what is happening across the world is what we call is controlled donation. So these situations where we talk that you have a cardiac arrest and then you think of taking the organs out, it's an uncontrolled situation. It's not in my control when the death is going to happen, right? And doing it at odd hours becomes impossible to organize teams across all centers in the country. But if you have a controlled situation is when electively care is withdrawn. There, these possibilities are more often. I come to it in my later slide. So this is again the data from the US, where we just discussed that the donation after cardiac death is increasing, and this is the green color in the bars shows the donation after cardiac death, and if you see that 30% of all donations, disease donations, are now from the patients with the cardiac death. Same is true for Australia. The UK is even step beyond that. There's now 44% of donations happening in 22 were from donations from donors who've had a cardiac arrest. So this trend is evolving, and we need to catch up with this trend to utilize more and more donors. And why is this happening? Why are donations after circulatory arrest happening? Because we got better care in terms of neurocritical care. Like, you don't allow brain death to happen, right? Before the intracranial pressure rises, you just take part of the bone out. So you allow the brain to expand, you don't allow the brain to herniate. And then you realize that if you have a futile situation, there's no point in having the patient on a ventilator for 30 days, or maybe 7 days, 10 days. It is all associated with misery of not only of the donor, but also the family. It results in loss of finances to the family. And if you know that this patient is not going to survive, there is no point in having him in the ICU, blocking care for other possible potential lives which can be saved with that available ventilator bed in the ICU. And now we have advanced directives of end-of-life situations, at least in the developed world, not in our country. We've had some legal battles going on in the Supreme Court, we've got some judgments out, but still it's not a wide practice. Although we do practice LAMA day in and out. I don't know how much is the LAMA rate at our hospital. Do we send LAMA? We send. We all send LAMA, right? I know PJ at least 3-4 patients every day they send left against medical advice. So it's not the ideal situation. Left against medical advice means that the patient is going to die either in ambulance or when they just reach home. Right, so it doesn't give you dignity of death. It's a very difficult situation for the family. So what happens in the West is that they allow this withdrawal of care in the hospital setting. They allow death to happen, and once that death happens, to the extent that sometimes they do this, the withdrawal of support is done in the operation theatre, and then that period of 30 minutes can be used to get the organs out if these patients are really. So as I discussed that LAMA happens everywhere. So LAMA is equal to withdrawal of life support. So we are practicing it day in and day out, but the only thing we are not doing it in the hospital. So that is the only policy we need to change. I don't think we need to make laws about it. We just need to put it into practice the withdrawal of life support. Organ donation after that is going to automatically follow. Let us not focus on it. We just need to do this. Okay, this patient is going to live. Let us withdraw the support and let him die peacefully. So once we have this practice, then subsequently the other things will follow. I'm sure there's going to be a lot of apprehension, and I would like to have any feedback or comments maybe once we finish this period. So uncontrolled donation is much more difficult. We've been able to do it because we've got a dedicated team and resources to do it, but it may not be possible everywhere, but the results are equally good. And we recently published our 11 years experience with outcomes as good as those with the donation after brain death. So the second growth in organ donation can come from extending criteria for donors, right? So that's again a big question mark where many patients are donated. So what are these extended criteria donors, right? So extended criteria donors are where there is more than 70% likelihood of failure as compared to an ideal donor who's died from brain injury, which means that he has no medical comorbidities, his organs are absolutely healthy, he's young, and these organs, and given compared to these organs, the extended criteria organ has a 70% greater likelihood of failure within the next 5 years. If the risk of failing is so high, why should we use this organ? Can anyone answer? I mean, looking at 70% failure rate at 5 years, I will never accept. Why would somebody accept that organ? Anyone? Just a common sense, it doesn't require any deep insight into literature. Why would you use such an organ if it's going to fail in 5 years? 70% chance is like very high chance. Yeah, so so far we've been treating organ transplant as one size fits all, but you cannot have an elephant and a bird having the same sizes, right? So it is not a one size fits all, right? You've got different needs for different people. You may have a patient who's 64 years of age. He's got a hepatocellular carcinoma which is going to kill him in the next 6 months. You give this organ, you can bridge him till the next transplant, right? A kidney failure patient who's not able to tolerate dialysis, gets frequent admissions, goes to the ICU every 3rd month, developing uremic neuropathy, which is irreversible, permanent. You would not, and he's on the waiting list where his turn is going to come after 6 years. By that time, his machinery would have been irreparably damaged. So you've got an opportunity here to give him that bridge, or that might be the best fruitful life he's lived for the next 5 years. So that's case scenario number 2. So again, road traffic accident injury. I don't know whether you're able to see the reports on the right side, but if you see the serum creatinine mentioned here is 6.5. Yeah, this is from our database. 6.9, TLC of 3000. Rest everything is more or less remarkable. So my question to the nephrology colleagues: so would you accept such a donor? Yeah, I think the answer is no. From most of you, the answer would be no. Why would I transplant somebody with a terminal kidneycyst? So this is again from our database what we have taken. So this patient was accepted as a donor, and he underwent transplant with AKI stage 3, and on top of it, with the papillary renal cell carcinoma. After doing all the benching and accepting him for transplant, that RCC was removed and the kidney was successfully transplanted. So he's now post-transplant 5 months, and last follow-up was done in July 23, and he enjoys a creatinine of 1.13. Normal kidney function, no recurrence of carcinoma. So the literature clearly shows that these injuries are all acute kidney injuries, and all acute kidney injuries, most of them would recover eventually with very little residual dysfunction, or some may have some residual dysfunction. So it is important to recognize and characterize that insult. You got much better means today to analyze it. I'll come to those later on, but you can accept these patients as donors. So coming back to our extended criteria donors, so So we got now means to it. So we had some definitions that, okay, you got anybody who's aged less than 60 years or aged 50 years with hypertension, stroke as a cause of death, or a terminal creatinine of 1.5, they become extended criteria donors. You can some more evolved scores, KDPI, KDRI, I will not go into those details, which can again tell you in a much better way what is the likelihood of these kidneys performing in the long term. So going back to the criteria, the age. So 70 years was the cutoff. It's not only 70 years. So what is the youngest donor you've done in your college or across the state? 18 months. Yeah. So do you come across people with children less than that age with brain death? You will come across, right? So this is an en bloc kidney transplant from a 10 months old donor, right? So we also used to stick to criteria. Earlier we had 2 years of limit. We had 2 years of limit as a cutoff limit. Before that, below less than that, we never used to entertain. But this is some we could do 10 months. This is on table picture. This is afterwards. So we could do that successfully. Based on this, we could actually go further. We could do a donation as age of 3 days, less than 3 days, 68 hours. After that, IKD has done again at 4 days. Right, so these are other examples what we have done. So these kidneys can be utilized and they can be made to work. And what is the highest cutoff? Is there any cutoff? Is there any upper limit?
We tried for 80 years old.
Kidneys.
1 month ago, 24 years.
So we learned the hard way.
1 month ago. 78 years old.
Yeah, so we learned the hard way. I mean, we started doing this about 10 years ago. I think we would have done close to 10 such transplants where we used only 1 kidney for 1 patient. But eventually what we realized that kidney function does decline with age. Despite selecting those patients with no comorbidities, no hypertension, we still ended up having kidney dysfunction starting as early as 3 to 5 years. And most of them actually, not all of them, but most of them actually ended up in CKD quite early on. So what we then moved on to that putting both kidneys in one recipient. So we've done close to 5 such patients now, and none of them has had an early onset of CKD as compared to the normal population. So this was a novel technique. Earlier we used to be transplanting 1 kidney on the left, 1 on the right, and then we improvised the technique which shortened our time and complication. Then we can put both kidneys on 1 iliac fossa, and that would produce equivalent results as compared to a young kidney. So it's like giving nephrons. So when you're giving, so this becomes an equivalent to a 35-year-old kidney, maybe not 35 years, but at least 50 years old kidney from a same single donor. So that's another next scenario. So diabetic donor, 5 years history of diabetes. Are you willing to accept? I want some input from the residents also. Please, who are the nephrology residents? Can I have show of hands? Okay. Yes. So would you accept this patient as a donor, or would you want to have some more information? Can you fill it aloud? So what all do you want to do? So these are the investigations. His HbA1c is, I think if you can read correctly, is HbA1c is 10, but urine routine is normal, kidney sizes are normal. Yeah, so you can actually go ahead, right? You can go ahead in this situation. So we've got some better documentations now. We've got some scoring systems available where you can access the damage which has happened either because of age or because of diabetes to the glomeruli, to the tubular interstitial compartment, to the vascular structures. You can rank them from 0 with no damage, and 3 is the maximum damage, and then you can decide that okay, should we use these or should we not use this. So this was an original article published in NEGM where they showed that kidneys from donors older than 60 years can provide an excellent function, provided they are allocated singly when this scoring is less than 3, the composite scoring is less than 3, and discarding when the scoring is more than 7, and for the in between 4 to 6, you would use both kidneys in one patient. Okay, so coming back to that diabetic donor, so we went ahead. Not many recipients were willing, but one of the recipients was a lawyer in the High Court. He accepted the offer, and we were very skeptical. He is a lawyer. Anything wrong happens, and we're going to be sued in the court of law. So we said, okay, we'll do a biopsy and then decide. So this was the biopsy report. So what's your take on this now? We talked about your scoring systems. The Rimouski score is what's the name. So what's your take on this biopsy? So is glomeruli are like 6 glomeruli are showing some mesangial matrix expansion. No definite evidence of diabetic nephropathy, but you got some mild tubular injury. Otherwise, tubular interstitial compartment is perfectly fine, and you got some vascular injury happening. What do you do then now? So the only person who is willing to accept is a lawyer, and this is the biopsy report we have done. Sorry? This one is post-transplant, I'll come to that. This one is definitely post-transplant biopsy. Allograft, it's good that you could point it out. But I couldn't get the biopsy before the transplant, but there was no change. So there was no change. The same findings were there prior to transplant. This was done, I think, about 4 years post-transplant. So we accepted it. We gave both the kidneys to the same patient. So this is 4 years old. So the changes are persisting. Diabetic nephropathy class 2B, there is no progression. We know that based on experience with pancreas transplant that if you reverse diabetes, if you cure diabetes, your end organ damage reverses. In 4 to 7 years of time, your end organ damage reverses, or it stabilizes, it does not progress any further. This patient had a new onset of proteinuria, that is why we did the biopsy, but we couldn't find any cause, and he's now stable on ARBs and ACE inhibitors. So which again brings to a question that, or the answer that, okay, one size does not fit all, so you can actually use for somebody who's not a non-diabetic. You can modify your immunosuppression, you can keep it as steroid-free immunosuppression.
We had experience actually. In 2014, we did one transplant. The recipient is relatively young. She had IgA nephropathy, on dialysis. But she was not at all doing well on dialysis. She couldn't tolerate dialysis. She was really suffering. No comorbidities and so on. That time when offer came from the Apollo Hospital, diabetic donor, is traced to 1+ proteinuria. But and there was a frozen section biopsy of the donor's kidney that showed a possible immense disease. Beyond that, they cannot be very sure of frozen section.
Absolutely.
So I was not for it, but when we discussed about that to her, she was bent upon getting it. So she said, come what way, I'll go ahead with this. So with after a lot of discussion, we went ahead doing that. The only thing we did is that post-transplant, we never gave tacrolimus. We prefer to give cyclosporine, that's not our problem. So that we were very careful in minimizing the steroid, bringing down the steroid dose and so on, so that she remained euglycemic. She did well. About 1 year later, there was a mild graft dysfunction. We had to go for allograft part. To our surprise, no trace of diabetes. Unfortunately, we didn't get that frozen section picture, so we couldn't accomplish that. So it's a personal experience, very hard to do.
So all these things can be thought of and can be put into practice. So coming back to the single versus dual transplants from the very young donors. So what is our age criteria? When do we use both kidneys en bloc like the one I showed, and when do we start splitting these kidneys to be used as individual organs? Anyone from the urology? Any resident from the urology or nephrology who wants to answer this? Yes? Do you want to answer it? What is our criteria? Forget about the literature. What is our practice here? When do we split the kidneys and when do we use both of them together? When the age, or do we have any age or body criteria? So, like say, somebody, I say 3 years old, pediatric donor. So, are we using it en bloc or are we splitting those? Are you splitting it or are you using both? Okay, unfortunately, like northern part of the country, we don't have many pediatric recipients listed for donation. So invariably, we end up in a situation where there's only an adult, right? So till some time back, we had about 5 years of cutoff, 20 kgs of weight, where we will use both the kidneys together. But if you are using both kidneys together, you are minimizing the number of your. So if you can do a split, and what we realize that you can go further down. So at the moment we have our cutoff as 2 years and 10 kgs. So anybody who's more than 2 years and more than 10 kgs, we offer a split kidney. But the literature keeps on advancing, and I could, while I was preparing for this talk, I could find that even less than 10 kgs they are now splitting. Why we so what they clearly say that for somebody who's they're down to now 5 kgs, so only less than 5 kgs they are offering en bloc, right? So it is possible to keep on extending this criteria. So this is our published experience with less than at that time 15 kgs was the criteria. Now it's down to 10 kgs. So if you see, the kidney is very small, like less than the size of the length of my thumb, right? And this recipient we recently honored, and she's about 5 years post-transplant. She's a lady and she's having a normal kidney function. The kidney is grown in size. So this way we can keep on increasing our organ donation possibilities. So we discussed about the AKI, we discussed about the DCD, circulatory death donor. We talked about biopsy, but there are patients with other medical conditions, including controlled sepsis and CNS malignancy. So I don't know what's your take on donors with controlled sepsis. Controlled sepsis means that the blood has grown Acinetobacter or say Klebsiella, but now he's controlled on antibiotics. Are we accepting those? No. So the second situation is that you've got a tracheostomy done, and tracheostomy culture is growing multi-drug resistant, but there is no clinical fever, there is no other signs of infection. So are we accepting those donors? Yeah, so even patients who had the controlled sepsis, if you give antibiotics and then you wait, and you can actually take them, provided they are not multi-drug resistant bugs in the blood. So if they are controlled, you can still proceed with organ donation. So that's another very interesting case. So this patient had the donor had a CNS malignancy, glioblastoma, GBM, right? So a clear contraindication to organ donation as far as the literature, as far as the guidelines are concerned. The guideline says GBM grade 4 do not accept as a donor. I will also not accept if I know it beforehand. So this patient, again, 64 years old, developing diabetic the neuropathy related, not diabetes, because of kidney failure. When we started the process, we were not aware of the histological diagnosis. By the time the patient were already consented and the diagnosis came, when we were trying to get the histology, the diagnosis came as GBM grade 4. As usual, the patients were all ready, the team was not ready. The team was not ready because they anticipated that if recurrence happens, then everybody is in the soup. So we did a thorough review of the literature. Although the guidelines still say it should not be done, but what we came across is that there is no reported death from recurrence after GBM as far as transplant is concerned, kidney transplant is concerned, and there have been reports, I think we reviewed about 80-90 cases which have been transplanted from these donors. Only death and recurrence has been reported in, I think, 3 out of 90, 3 or 5 out of 90. And all those patients could be saved because of timely explant of the graft. But all the remaining 75 or 85, whatever the number was, they could still proceed ahead. Whereas other organs, liver patients had died because when you take the liver out, there is no other possibility for them to survive. So now this patient who was 64 years old, he was staying in India, all his family was in Australia, he was not able to go and join his family. So he became desperate and said, I take all the risks. He went ahead with transplant. He's now 5 years post-transplant, 3 years post-transplant. We're doing an annual PET CT, there's no recurrence so far. So this is the only one we have done, but that again shows that, okay, you have possibilities. Don't close your windows based on your medical comorbidities. And there's no one size fit all in organ donation. So coming to the next part, how else the future growth is going to happen. So this new technology coming up, normothermic organ perfusion. Historically, organs were always kept in the ice, but now it is possible to keep them perfused with the machine, assess how much is their function. We were lucky to have this machine with us, and we did a preliminary experience in 10 such situations where patients had acute kidney injury. We would put them on the machine. You can see the kidney starts to make urine. You can access the function by seeing the reduction in potassium or reduction in serum creatinine, and then you can decide whether this kidney is usable or not. Before this machine, we utilized the cardiopulmonary bypass machine. So you can see the flow parameters. So if the flow in the kidney is good, that kidney is usable, even if you don't have the other parameters to assess. So this is one of the examples where we actually could use a kidney based on the parameters of this machine, right? So we had a patient who had a potential brain dead donor, was being evaluated, but he was hypotensive despite being on 4 inotropes. We could not bring the BP up. So at that time we decided we'll go ahead with the donation after cardiac death. We explained to the family that if such things happen, so we'll proceed. But what the literature says that you need to have a minimum BP, because if your BP falls to less than mean of 50 for a very prolonged period, you're going to have a ischemic insult to the kidney, right? What we call as a warm ischemic insult. If your blood pressure stays less than 50 for more than 2 to 4 hours, that organs, they are unusable. So this is what the current understanding of warm ischemia is concerned, right? So here, by the time this patient had an arrest, it was more than 7 hours, right? So clearly not a usable organ as far as the guidelines are concerned. So, but since the process has already been set up, so by the time the cardiac arrest happened, the donor was shifted to the theatre, the process already started, we took the kidneys out. My colleague said, sir, kidney appears to be okay and it's completely flushed out, what do we do? So it's a bit question mark. You cannot transplant this kidney into anyone just like that. So we thought we'll put the kidney on the machine. We used the kidney on the machine, kidney started to make some urine. We looked at the perfusion parameters, they were within the reasonable limits, and we transplanted this, and this patient is now, I think, more than 3 years again with the kidney function of 1.1, right? So all this is possible. So this is how growth has happened at our center. Before 2008, we used to have 1 odd donation in 2 years. That's the time when we started to put all things in practice. We had our leadership which supported us, as is being happening here, which is, I think, the crux of all organ donor success stories. We had our transplant coordinators in place. We started with 1 coordinator, had some results. We added 3 more coordinators. But the big jump came only when we started accepting these extended criteria donors. And when we started counseling them right in the triage, rather than taking in the ICU, and then we started counseling in the triage itself, that this is a desperate situation, he's not going to make it. Once they accept that it's a difficult situation and life is not possible, that is the time they can actually consent without being in the ICU. So numbers all look good, but we need to have outcomes in the long term, right? So next 10 years, I think this is the area we again need to focus on. Are we, what we are doing is correct, right? So for that you need to have registries. So this is an example of a registry which have been set up locally by us. We don't pay any maintenance fee for it. It's made only for one time. So currently houses about 4,000, data of 4,000 over the last 20 years, recipients. And same for the donors also. So we got an invite from the Asian Society to share your long-term outlook of the donors. We tried to find it out. So what all things were there. So these are all the different parameters, the demographics, the pre-op investigations, the operative records, the course in hospital, and then the follow-ups, right? So what we found out was that over a period of time, the follow-up has improved, right? So earlier we were looking at only 30% follow-up rate, which has now improved to close to 90% based on the interventions what we have done. So what we were surprised to see, so do you accept donors, living donors with history of hypertension? Yes. So is that proportion increasing or still same? Increasing, yes. So 2005, I think at that time we were very reluctant to accept anyone as a potential donor if he has hypertension, right? And now that proportion is 11% in our series. It actually worries me. It worries me because not all patients with donors with hypertension are going to do well in the long term. Right? So before 2007, hardly any patient with dual antihypertensives. And now, a lot of them. Right? Even on two antihypertensives, we are selecting. Hypothyroidism, 10% are hypothyroid now. So we need to have long-term data of this, what is happening to them, right? So our data also follow-up may not be 100%, but what we have found is that at least 6 patients developing proteinuria, 2 going on to stage 2 CKD, 3 of them actually requiring renal replacement therapy, 1 was temporary, but 1 had to be transplanted and 1 eventually died because of CKD, right? So as we expand, I think we need to reduce our expansion in the living donor and focus on the disease donor. Right? Disease donor, if we are expanding criteria, nothing more damage is being done to the donor, right? But in the living donor, that possibility is there, so we need to be very skeptical about that. And that all we can only know if we have the registries. Unfortunately, these registries are not there. We've got central institutes, we've got all the states working up, but we still are not able to formulate a registry which shows what is happening to these patients who donated their kidneys or what is happening to the transplants which have happened, which we, I think, definitely need to do some work in the next decade. Can we do it? Why not? Right? So this data from Aadhaar transactions, a very simple mobile app, and you've got 2.3 billion transactions happening in 1 month only. We've had the largest vaccination drive, all mobile based. So we've got all the technology sitting here. We have the cheapest lever, I would say, to drive this technology, right? If we can go to the Mars, I think registry is a very small thing. Now we even touched the sun also, right? So definitely it's possible, and I think the only the administrator has to be sensitized. The people who are in control of the process. I think Transplant we had a very good discussion regarding how to improve this and how to inculcate this as a part of your registry. So I think we need to work on that. And lastly, while we were sitting on the dais, our dean, Vati Dean, he asked me, what is the success rate of pancreas transplant? Do you do pancreas transplant type 2 diabetes? I said, yes, we do. I'll give a talk on this. So I'll again start with the case scenario again. Very typical history. I don't know, do you see type 1 diabetes amongst your kidney failure patients? Do you have type 1 diabetes also? Not a big deal. Yeah, same was situation with us also. Type 1 disease happens very early on, right? The family gets exhausted with while managing, and they just lose hope. And even if they undergo transplant, the outcomes are not great unless the diabetes is taken care of. And type 1 disease is a very different disease from type 2, right? Type 2, you can take 2 tablets, 1 tablet for 20-30 years, nothing happens. You go on to then exhaustion of your beta cells, you require insulin, but that also insulin, like you got fixed doses, very little variability. Type 1 is a very different disease, altogether different disease. One moment your sugar will be 50, you have one snack, your sugar goes to 500. Very challenging. To the extent some patients, some of our recipients have had somebody sitting with them all the night. They just go into hypoglycemic coma in the middle of night, right? So this is the type of illness, very different, very difficult to manage. And families under a lot of stress. Some as young as 2 years of age, we've had multiple insulin injections. Despite that, they end up having kidney failure very early on. So around 24 years of age, she came to us with family had lost all hope. She was tried on dialysis. She lost her job. She was nurse working in some remote PHC. So that was the answer. Like if you do pancreas transplant, this is data coming from the Japanese society. Japan is a very advanced society. They manage diabetes very well. They've got all the technology in the world. They put your real-time sensors on the patient to have a real-time glucose monitoring. They have glucose pumps. Right now they have pumps which can sense the glucose and then give the insulin. Despite all that, you still have a significant difference in death happening over the long term in patients who are diabetic renal failure, right? If you go further to the US, the differences are even more stark, right? So the bottom line is patients who are on the waiting list for the pancreas, the top list are who had a transplant. So the huge difference happening as early as 10 years. There's almost 30-40% difference in survival. So she was lucky that she could get we have just started our program, not many patients on the waiting list, so she could actually get the transplant done within a couple of years. Had some problems in the post-op, but she recovered eventually. And she could get her job back in a remote PHC. She gets married in 2021, goes ahead with pregnancy, has an elective LSCS at term, delivers a healthy baby, was widely captured by the media all across the country, and the child is now about 2 years old. Great success story for the family who had thought that this girl is not delayed, right? So this is the data regarding the pancreas transplant happening in the country, right? The bars in the yellowish brown are from PGI, whereas the brownish red are from the national data. So we're close to 50% of pancreas transplant in the country. But that's a serious problem. Why should one center be doing such a high proportion of an organ transplant across the country? Is that transplant not good? It's not so. If you see the Western data, the success rates are equally good. We do close to 1,000 donations in the entire country, right? So if you are using only 20, 30 pancreas, which means we are discarding the rest of the organs. Although the criteria, the acceptance criteria for pancreas are very stringent, but world over at least 20%, 10 to 20% of organs are definitely utilized. So we are losing, so we have those organs, we have those patients, and we are just not able to join the dots together, right? So where is the gap here, right? The gap is here in the trained professionals and awareness. So we need to bridge that gap. So these are another examples that sometimes we have the pancreas, we don't have the kidney. I'll come to that. I'll just skip that. So this is the first World Consensus Conference on Pancreas Transplant, which happened 4 years back. And these were the findings. So almost 597 studies regarding pancreas transplant were discussed, dissected at length by 51 experts, which led to the conclusion that if you do a pancreas transplant along with a kidney transplant, you actually improve the survival in the long term. Till now, pancreas transplant was only thought of that it just gets rid of diabetes. But now we got real data which shows that you are going to live longer if you have a pancreas transplant along with a kidney transplant at the time of surgery. to have a slightly increased risk of mortality. Pancreas is a very unforgiving organ if you mess with up. Right? We've had an example, I think in Tamil Nadu only, like way back in 2008, there was a pancreas transplant happened in an army wife where that lady died and the case went to the court and the surgeon had to quit the country, first leave the profession and then quit the country because the court came with very stringent punishment to that. I don't know whether Tamil Nadu or Karnataka, possibly Karnataka. So pancreas is a very unforgiving organ, but at the same time, the results are excellent. You cannot imagine the change in the quality of life. I mean, a lot of recipients will come and tell me, sir, I did not know that the life is like this, right? From having every time monitoring your sugars and not able to eat anything sweet and monitoring injection insulin. So it's a life-changing experience for those who had a successful outcome. Along with that, it has the potential to reduce the chronic complication of diabetes. Whatever is the therapy available today, whatever technologically advanced therapies are available, they do not alter the risk of long-term complications. They only delay them. You cannot avoid diabetic retinopathy, neuropathy, even with the best of possible medical care, right? You cannot achieve euglycemia. This is the only therapy at the time, along with islet cell transplant, which can achieve euglycemia. And the SPK should be performed shortly before the initiation of dialysis or just as the dialysis has started. Why? Because dialysis in a patient who has diabetes has a very negative prognostic implication the more you wait, right? The vascular disease progresses at a much rapid pace in diabetes as compared to a normal. Our own data shows that those patients who are waiting for on the SPK list versus the kidney list, you almost have a double the risk of mortality. So 34 patients, I think, have 1 year mortality while on dialysis with on pancreas waiting list as compared to about 10% on the kidney waiting list. So there's a huge difference there. Which brings to me, why is the pancreas numbers not growing? So this is the reason, I think. World over, kidneys are allocated with the pancreas, which means that if you are on the pancreas waiting list, you get kidneys much earlier as compared to being on the kidney list. So that is a problem which I think as in nephrology and the transplant community is holding back, that why should these patients get a preference. But I think somewhere we have to give some compensation, either we give some scoring points, we give some advantage. So some kidneys should travel, not all of them. Given the number of donations we have, I think we start offering them, and we have listing all kidneys possibly will go with pancreas only, the kind of demand we have. So we definitely can not let all the kidneys go with the pancreas, but some allocation has to be done so that this program starts to develop and these patients also stand a chance to live a normal life. So coming to the next question, the questions are asked, do you do transplant in type 2 diabetes? Because type 2 diabetes, you are already full of insulin. It is the resistance which is making you hyperglycemic. But the current literature, it used to be once upon a time, it used to be absolute contraindication for pancreas transplant. But the current evidence shows that over a period of time, you got a beta cell death happening in patients with type 2 diabetes, and even if they are still having insulin, you got some criteria. So your age should be less than 55 years, your BMI should be less than 30, your insulin requirement should not be more than a unit per kg body weight per day, fasting C-peptide should be less than 10, and if you're surgically fit, you should do benefit from this. We've had, so far you've done only one such patient who was, because your type 1 list is always too exhaustive, so type 2 will never get a chance. We always tend to prefer type 1. One patient with AB group, AB is a rare group, so he could get a chance. So he's now about 3 years post-transplant. He remains off his insulin and his kidney function remains all right. So coming to the last part of my talk, the technology. So I thought that this going longer and longer, so I just restricted this. So what is going to happen in the next decade? So some of things I have already started to happen. Are we doing genotype-based dosing? Genotype-based dosing in here? No. Because I saw some reports from Tamil Nadu where they are doing the genotype of the patient and then deciding what dose of tacrolimus. Polymorphism. So we are already doing it. So you are going to have some AI-based elevation. AI is coming, artificial intelligence coming in a big way. So they can tell you, okay, this is an organ, this is a recipient, this is the projected lifespan. So at some point, we have to move from a time-based allocation. Right now, the allocation depends upon how much time have you been on the waiting list, right? So that doesn't give you the best outcomes, right? If you want the society to prosper in the long term, we need to switch to the AI-based models, right? You want to have the maximum utilization of the organ, the maximum time utilization, right? So if my recipient is going to live for 5 years, I give him kidney which can work for 20 years, that's not the best use of that kidney, right? Which means that the society is getting deprived of those 15 years of useful life of an organ. And these can be answered by the AI-based allocations. So we need to move in this direction. The world has tried to think about it. There's a program going old for old, which means that the older kidney should be given to the older patients. You should not transplant an older kidney to a younger patient. The world has tried to move in that direction, but they're still not there. But that's a potential to it. We've got excellent technology as far as gene editing is concerned, and we discussed that example of pig transplant. So that's 10 gene edited pig. That research has taken 20 years, starting from early 2000, where they were just trying to get some genes knocked out from the pig. So it looks very easy, but these pigs have been brought up in a virus-free facility for the last 20 years, and they kept on doing the whole genome. They kept on taking out one gene by one gene and trying to see what is the response. And then they realized that even if you take the genes out, there's still some problems. And then they inserted human genes into the pig genes. So now this 10 gene edited pig is the one whose organs actually could be used with the same standard immunosuppression as you are using for the human organs. So I don't see that thing coming to India in the next 10 years, but you never know. I mean, a lot of work is going on tolerance. Tolerance is when we are able to transplant without any immunosuppression. So has anyone seen the nephrology residents? Have you seen any patient who just stops immunosuppression and comes to you after 3-4 years and his kidney is doing well? So it happens. Once in a while it happens. Not all of them. I will not. Yeah, so I mean, once in a while somebody will come, sir, my medicine nikha raha, main theek chal raha, what to do? I mean, the advice still is to start the immunosuppression as early as possible, but occasional patient behaves in this way. Why it happens, we don't know. Nobody has the answer. So there is a big tolerance study done across the world, the tolerance network study, where they collected blood samples, did the genomic analysis and everything. They were not able to find the answer, but then this exists. And some of the work has already happened that we are able to create tolerance in a way which is at the moment not clinically applicable. Means that if you do a bone marrow transplant along with a kidney transplant, especially for multiple myeloma, you are able to achieve tolerance. That is the best proof. They are on no immunosuppression. Coming lower than that, I mean, moving a little lower, then don't do a complete bone marrow transplant. Just do a lesser than that. We call it a microchimerism. Promote a microchimerism means that you got both donor and recipient bone marrow cells happening. So you are able to achieve that, you are still able to get away with most of the immunosuppression. But research is progressing in a very fast way. You've got some molecules, unfortunately, they led to some toxicities. They could not be put into clinical practice, but we definitely hope that more of such clinical use will probably come in the next 10 years. Organ preservation is already there. So it's already there. You are now using clinically normal therapy has come up in a big way, especially in the liver transplant. And the next is to step to frozen organs. So if you have a kidney, put it in the frozen, then you can use anytime you want. So that may not be clinically viable at the moment because your organs are, the recipients are always there for the organs, but if you have pig organs coming, then this technology will be required. And lastly, I just want to share our experience in establishing transplant as a separate specialty and has it helped the program or not. So first transplant was done way back 50 years. In fact, last year we celebrated 50 years of transplantation at PH Chandigarh. We had a dedicated ICU and OT complex in 1996. And we created a separate department in 2005, only catering to kidney transplants. We started the pancreas transplant in 2014 and a surgical training program. Started with a fellowship in pancreas transplant in 19 and an MCH program in 2020. So my experience with this has been, I've been associated with the department since the year 2000. So I think creating a separate specialty helps. If not a separate department, but having a special manpower only focusing on a particular surgery helps. We've had people who like liver transplant also started at the same time as the pancreas at PJ. So while we are at the number 1 in the country, they are still struggling to establish themselves. Right? So total 43 pancreas transplant we have done. Liver transplants number is about 60 or 70 or something like that. Still struggling, right? And what has happened with this, there are added advantages. When we started our MCH and fellowship programs, I was not sure whether there will be any candidates coming for this program, to be very frank, right? Before this, we used to have residents, they will work for some time, then some will write here, they're at USMLE, some will write their MCH in urology, they'll just go in this. I was not sure whether we're going to have any takers or not, but I was surprised. The best of the people started to join after leaving MCH courses at other places, including MCH in neurosurgery at All India Institute, MCH in trauma surgery. So I was surprised to see. But with that, we could actually get all this research going on, with the projects going on. So it actually raised the bar of our program to a much higher level. Right? We got our first MCH resident got a $50,000 grant from the Transplant Society based on his work of the first thesis topic of normothermic preservation. So that dedicated manpower helps you a lot, and that's an adjunct benefit what we have done, that we could develop the vascular access program. So vascular access is the backbone till the time these CKD patients wait for transplant, right? So we could do a lot of work in that. We could improvise. We often have patients who got, I think nephrologists will realize, who got bilateral central stenosis. What do you do for them? What do you do for patients who have bilateral central vein stenosis, no vascular access? You can put them on CAPD. CAPD, not everybody can afford, at least now. You are lucky in your state, everybody's medicine, everything is free, so you could use the lower limb access. We could publish that. We could develop an angioplasty based on ultrasound rather than CM only, which can take care of your stenosis. We could start cannulation of your radiocatholic fistulas as early as 2 weeks, so you don't wait for 6 weeks now. If your ultrasound parameters are fine, so you can actually start dialysis as early as 2 weeks also. So this is a side benefit on the vascular access program. And this is the list of research based on these developing into specialty. So we could enter into it's a long list, and I could have added more to it. So that's all what we could do. So with that, I'll come to the end of my talk, and to summarize that I'm sure that we're going to see a tremendous growth over the next decade. Right? We're just touching the tip of the iceberg. The potential is 100 times the number of disease donation, at least 2 to 3 times the number of liver donations. That is what the country needs, right? Earlier finances were a limiting factor, but with Ayushman coming into picture, the game has certainly changed a lot. I do see development of multi-organ transplant already is happening, at least northern part of the country where the donations were not happening. So at least two states have initiated this development of multi-organ transplant programs. And novel strategies are going to be utilized more and more often in the next decade to help increase the number of utilization of organs. And there's a lot of work in progress which is going to happen and lead to better outcomes. With that, I will again like to thank the audience for a patient hearing, and Professor Gopal Krishnan for inviting me here to escape the cold conditions at Chandigarh. Chandigarh at the moment is having a freezing cold, and it's very warm and pleasant here, and I had a very nice experience coming here, talking with you, interacting, knowing what the Transplant. Thank you very much. questions or?
Western world and different Australia, they have to distribute disease. In fact, that kind of Australia has like you said that it makes a most of the difference between
The times, so there are two times as far as so there are two times which we talk in context of donation after circulatory arrest. So first is the time, how much time should you wait before you declare a patient dead, right? That is talked in the context of that now you are doing a cardiac transplant also, right? So cardiac transplant means the heart is not dead. So the time, the context of time in terms of this is at least 60 minutes is acceptable. Up to 2 hours for kidneys, 30 to 60 minutes for the liver, for kidneys, 30 to 60 minutes for the liver, and then the centers, some centers went, in the Spain went till 4 hours, and then this regional perfusion things come. So it's very rapidly evolving, very rapidly evolving.
You had 40 in 2022, 16 in 2020. Of course, we are rising, but at some point of time, we will also come to that stage where you offer plans for technical examination. Right now, the reason for that is a very sharp difference, 60% difference. Is there any specific reason?
Yes. So see, there are always challenges when you are growing, right? So if you are flying,
We can do something to prevent that arrest here, that kind of no reason.
yes. So specific reasons is that so some of them are administrative reasons, some of them are leading to this wider acceptance of this marginal kidneys, and somebody will say no, we will not going to accept this. So that this is the difference. If you are only accepting marginal kidneys, standard kidneys, you end up doing 16. If you are accepting marginal kidneys, so 2023 no marginal kidneys are accepted. So that's a policy change brought by the administration change. So those are challenges you have to face first. Thank you. It is possible to do that. So viability.
What happened here was sometimes we had immediate challenges of death. And once we released the plan, we didn't have hypotension and as well. So we are thinking that the viability of this issue was not.
So very relevant point as far as disease donation is concerned. This is because of ischemic damage, and sometimes ischemic damage is not perceptible, not to your naked eye. Organ retrieval team, right? Very subtle changes in the disease organ retrieval can lead to very different outcomes, right? We've had situations where the resident just, before applying the aortic clamp, he just keeps on pulling the aorta for a very long time, leading to occlusion, leading to unknown ischemic damage to the kidneys, not reported. Right? We've had situations where the perfusion fluid was hanged for 30 minutes, right? Cannulation did not happen. Perfusion fluid attained the normal temperature. So these are situations, these ischemic kidneys, when you transplant them, they will lead to immediate release of acidosis, hyperkalemia, hypotension, requiring immediate dialysis or death. So normothermic is a way to do it, but better way would be to avoid all this. Better training, better education, more awareness regarding these possibilities. But if you keep these kidneys on the machine, you can't do all them. It's an expensive thing so far, but that's the only way. And you will not pick up this on histology also. Ischemic damage does not appear on histology. It takes at least 48 hours for the ischemic damage to manifest on histology. Right?
Your experience, if a center is planning to start DC, which would you advise? Controlled or uncontrolled?
Best is controlled. Best is controlled. Uncontrolled, will have all these problems, uncertain times. A lot of logistic support is required, immediate available of theatre, your labs. Allocation is very challenging there. And then on top of it, the ischemic damage. And then the risk, kidneys may not function. You've done all the transplant, done all the hard work, patients paid all the money, and the kidney is primarily not functional. With controlled, you know what is happening, so all those fears go away. With the control, the only challenge is that not many intensivists, neurosurgeons are able to accept this, having the patient dying in the hospital. That is a big challenge. So we need to break the ice in one or two particular institutes, and then only the word can spread. Happens across the world, why not in ours? Little interaction from the residents. So is transplant not a favorite specialty? How many of you are surgical residents? So not many. Okay, there are a few. So do you like transplant as specialty, or do you are happy doing other work? India doing, if not 100, at least 50 times donations. So it is only going to happen if people are there in this area at the cutting edge. Thank you.